I think we will start now. We might as well with the welcome and introductions. I know I was just telling Shelley, I see your comment in the chat. I was just telling the group how this is a very popular webinar. I mean, I don't know how many people are going to attend live, but I think it just speaks to the importance of the topic, talking about menopause and bone health and what we know about this topic. So thank you, everyone, and welcome to our webinar offered by the Canadian Arthritis Patient Alliance with like some amazing speakers, which I know Natalie will introduce later. Just so you know, we are recording this. So, I mean, you're feel free to hide yourself, turn your camera on or off or whatever. The recording will really just show the speakers and the panelists at the end like on the public recording. But so anyways, just wanted to let you all know in terms of that. Before we get too started, just wanted to acknowledge that I live, work, and play on the ancestral and unceded territory of the Anishinaabe or Algonquin peoples and the place known as Ottawa. That's where I am based. And I know we all come from different parts of Canada and, may want to reflect now on the land that you live, work, and play on and the uh, the indigenous peoples who have cared for and stewarded this land for so many millennial at the end of the day. Um, in terms of the agenda, so I'll just spend a few minutes on the introduction and the welcome. I'll pass it over to Natalie Boivin, who will be our moderator and managing things from that point onward. We will have a presentation of about 15 minutes by Kaira Naidu, and she'll be speaking about the Menopause Matters Study, which was launched and executed from the University of Cambridge, where she's located in the United Kingdom. Like interestingly enough, I was at the Euler Congress, a big European Congress, and Kara's research was quoted in the session I attended, not just once, but twice. So I think it is really helpful and meaningful information that people are looking for. That's for show and shows the evidence gap here. It'll follow by a moderated panel discussion by Natalie Boivin, along with our panelists who she'll introduce. And just wanted to make a note that, the information here is really general information to help you learn a little bit more. It's not personalized medical advice, and I'd encourage you to speak with your healthcare provider, your rheumatologist, or any other specialists or physicians about that sort of more detailed information for you. And so with that, I am going to sorry, I realized I wasn't pushing my slides forward, but I am going to briefly introduce Natalie Boivin. So Natalie is involved with the Canadian Arthritis Patient Alliance. Um, uh, she lives in Ottawa. In 2016, she was diagnosed with a rare autoinflammatory disease while living and working as a prosecutor in northeastern Ontario. And so I really feel like it's serendipitous that I cross paths with Natalie, and she's gotten involved in so many different things and bringing her advice to different CAPA projects, but also she has become a patient advisor for the same hospital she gets cares at, and as well as the Montfort Hospital, which is a Franco-Ontarian hospital in Ottawa, the only one in the province. So with that, I'm going to pass it over to you, Natalie, to carry things on.
Thank you, Lori. When I heard about this webinar, I was very excited. A lot of us, with or without rheumatic conditions, are interested in our bone health as we age. Our guests today, I know Lori's alluded already to Kaira Naidu, who's a health economist and researcher at the University of Cambridge, and she will speak to us about Menopause Matters Study under the supervision of Dr. Melanie Sloan. And she will present first. And the other three panelists with whom we will discuss bone health and rheumatic conditions are Dr. Carrie, who is a rheumatologist and professor in the Department of Medicine at the University of Alberta, and Dr. Carol Hitchon, a rheumatologist and researcher and she collaborates on national and international research initiatives aimed at improving health outcomes for people living with rheumatic conditions. And last but not least, we have our patient with lived experience, Linda Roy. She will give us her perspective as well during the panel of living with a rheumatic condition and her experience dealing with the topics that we'll be talking about today. So a couple of things to keep in mind during the webinar. Lori already advised that you can keep your cameras on or off. We would ask that you mute yourselves if you can, so that we eliminate any background noises. There is English and French captioning available. So if you go to the bottom of your screen, of your Zoom screen, where it says more, you click on that and show captions. You click on that as well. We want to hear from you as participants in this webinar. We would ask that you please put your questions in the chat. We will see how it goes. We will either answer those questions during the discussions themselves, if there's a bit of a lull, or during a dedicated question and answer session at the end of the webinar. Pour les observateurs francophones, vous pouvez activer les sous-titres en français et aussi poser vos questions dans la boîte de clavardage, le chat, et cela sera traduit si le besoin en est. Again, we ask you to keep your questions general. Lori has already commented on that. And lastly, there will be a survey at the end of the webinar. It will be in both French and English. And we hope you will answer this at the end of the webinar. It will be, again, in the chat, and your input helps in preparing future webinars or information sessions. So without further ado, we will start with Kaira Naidu, who will speak to us about the Menopause Matters Study.
Hello, everyone. Can you see my screen? Yeah, great. It's so good to be here. Thank you for having me. I'm Kaira, and I'm a researcher here in the Menopause Matters team at the University of Cambridge under Dr. Mel Sloan, and she leads the long-term conditions research group here. So today what I'm going to do is share some snippets of our research. So this research is actually how I met Lori in the first place. And I'll just be going over some of our preliminary findings. So just to begin with and set the scene, first of all, I will be referring to SARDS a lot in this presentation, and that will stand for systemic autoimmune rheumatic diseases, such as rheumatoid arthritis. And I will get to specific rheumatoid arthritis or inflammatory arthritis statistics later, but in general, just to set the scene, women do make up a large majority of SARS patients. So as you would know, 75% roundabout of rheumatoid arthritis patients are female. And of course, many of them would have gone through menopause or will end up eventually going through the menopausal transition, which will be around 45 to 55, sometimes earlier, especially for people of color. This is when there is a cessation of ovarian function, a drop in hormones, and that might lead to a lot of symptoms such as hot flushes or night sweats, pains. You might all understand. Sorry, what is happening to my, there we go, yeah. And of course, HRT is a very hot topic here because that's how you supplement hormones, and it's quite well recommended by a lot of medical guidelines, especially for, let's say, the general population of people who don't have any direct contraindications. But this is also a very important topic when it comes to SARS or arthritis in general, which I'm sure we'll all be getting into a lot today. I have spent a lot of time interviewing patients, and this Venn diagram that you see in the bottom is something very interesting because we see that when I ask patients to tell me what the symptoms are and try to link or ascertain whether it comes from their SARS or the menopause, I see that there is a massive overlap and a lot of confusion because so many of the symptoms feel similar, like joint aches or stiffness or pains, and it becomes really hard to differentiate where it's coming from. And when you don't know what is causing what, it also makes it harder to treat it. One thing that I've also learned is that menopause is a time in people's lives where there are a lot of life events. So your children go to university, parents get sick or they need help, work gets really busy, and it becomes even harder and harder to figure out where the fatigue or the pain is coming from. quick introduction to our work. I'm not going to bore you with our study objectives, but broadly it is to understand the relationship between menopause and systemic autoimmune rheumatic diseases and the role of hormone replacement therapy. So we look at the impact of menopause and lived experiences at the core of it. So we work with patients as well as clinicians. We had this international survey. That's how Laurie and I met, as I told you before. And a lot of our data right now is self-reported because we truly believe that patients are experts on their own lives and conditions, and they can actually make very good judgments of the same. A lot of Mel Sloan, who is my supervisor or boss, her research has shown this time and time again. So our ethos is really to listen to what patients have to say, and that's what I will be telling you about today. And of course, to have a complete image, we also survey and interview clinicians. Sorry, I think PPT has a mind of its own. It's just randomly moving the slides. Anyway, where was I? Yeah. So we also work with clinicians. And one very important part of our work is that there is nothing that we do which is without working with patients or those with lived experiences. And they are a part of our research team, equal to all the researchers and doctors. We don't do anything on behalf of patients, but we work with patients and for patients. And I'm really excited to show you our work. As Laurie and Natalie have mentioned before, none of this is medical advice. And a lot of this is just patients' lived experiences. There are people just like you, some with RA, IA, other diseases, some from continents away. So really today, I am just a messenger. And some of the work I will show you today is going to be preliminary, and I will let you know, but hopefully you'll have enough takeaways. So, what we have found out is while we were trying to figure out the landscape, SARS patients do report very low satisfaction with menopause care. And this is significantly worse than people who do not have any rheumatic diseases. And we looked at lots of different domains. This goes across the entire, span of care for menopause, starting from the availability of clinicians all the way to any follow-up support or clinicians' empathy. And when we look at patients' perspectives, what I found with lots of interviews with patients is that there is a lot of reactive care, which means that a lot of patients have this burden of advocating for themselves. So menopause care is only provided when patients explicitly go and request it, not something that's proactively raised by clinicians, which means that if you are a patient and you do not advocate for themselves, there's a really high chance that you might not end up receiving any support at all. And women, oftentimes, through our interviews, we found that they internalize the silence. So something like, oh, my mom never asked for help with menopause. Should I ask for help? And they question if something as natural as menopause should even be discussed, right? And when people do end up asking their doctors or do end up receiving care, they often tell me something like, oh, it's just because I'm a clinician myself, or my sister's friend took HRT once and that's where I heard about it. And it is understandable for a lot of clinicians in their own specialties because you have very short consultation timings. And for a lot of them, they might feel like they have bigger fish to fry in those 10 or 15 minutes that they get to see you. But at the same time, it is also not fair for the onus to fall completely on the patients themselves. So it's really important for clinicians as well to keep an eye out for this particular demographic and be cognizant about the fact that menopause actually might be an undercurrent, playing a very important part in this life stage for women. And when it comes to HRT, it's interesting that patients report that HRT discussions are very superficial. And they would rather discuss some benefits really quickly, like, oh, it'll help you with your bone density, might get rid of hot flushes, but there is not enough time or knowledge to appropriately discuss risks, especially considering the underlying rheumatic condition. And some patients have described this as an experience in which you're just given some tablets to take. And HRT, as I have learned through my hours and hours of talking to clinicians and patients, is much more than just a medication because, first of all, of course, keeping aside any obvious medical contraindications, it also depends a lot on people's own belief, preferences, and lifestyles. Now, full disclosure, I am not an HRT expert, but our research and experiences have shown that when it comes to a decision to take HRT, there is a lot more that comes into play. Now, I'm going to give you 2 examples to explain this, and that's what I've learned from my interviews. So for example, some people who have pets or are very cuddly with their family members, Some doctors would ask you to be careful with any HRT that goes on your skin, like, for example, a gel, because there have been cases of people's dogs absorbing the cream and then developing health issues or going into heat. Sometimes when I speak to patients who are neurodivergent, they tell me that they're quite inundated with already the giant host of medications that they have to take. So they prefer to have a patch. You put it on, forget it for a few days, and then you replace it. And that's exactly why detailed and considerate conversations are really important when it comes to HRT. But unfortunately, we find that it's not very common. Then we do see that there is a siloed care between specialties. And this is very true for the UK NHS system. I'm not entirely sure what it would be like for the Canadian healthcare system, but I'm sure you would understand what it feels like to have to consult multiple people for answers and options. And this siloed care also means that menopause and the rheumatic disease are separate clinical issues, and you don't really know who to go to talk about this overlap. And of course, this does preclude any sort of holistic care for patients. But at the same time, it is also quite stressful for some patients themselves. Interestingly, we also worked with clinicians, as I told you, and their perspective matches up really well. And this is what we're preliminary calling ping pong patients. And that's actually a quote from a clinician that I interviewed who mentioned that in a patient's journey, they are stuck between different specialists who own have their hesitancies. For example, a rheumatologist might not be very confident about HRT. Likewise, a gynecologist or a GP might be worrying about their underlying rheumatic condition. So there's this mutual hesitation, and that often leaves a lot of patients in this void where no one's really taking care of them. And when clinicians do, take initiative to do any personal collaboration or ensure that there is a very smooth coordination, it can be very uneven. And this is oftentimes what we are calling now like a postcode lottery. It really depends on where you live, what services you have. I am also going to take the liberty of sharing some work by my very excellent colleague, Sydney Taylor, who works on health inequalities in autoimmune rheumatic disease care. She's done some amazing work. And one of her preliminary findings, which I'm sharing, is that through her interviews and surveys, she's learned that there tends to be a biological dismissal across the life course for women, which means that a lot of participants say that there is this pattern in which anytime they have a physical symptom, it's very likely that that will be attributed to a reproductive or hormonal cause, and that often forms the ground for dismissal. This patient's quote here encapsulates the message perfectly. I'll read it out for you. I was told it was my hormones when young, my hormones when older, and post-menopause, my hormones again. Now I'll quickly jump to the topic of HRT. We were curious to see how many people are using HRT, how commonly is it used, and what are their concerns or barriers. So here you can see I have other diseases as well, just for comparison. RA and IA is somewhere towards the middle. You can see I've circled it. And hopefully this helps you gauge the engagement with HRT. And as you can see that people across all stages of the menopausal transition, for a majority of patients from these disease groups, do not end up taking HRT, which is the purple side of the bar. And that can be for a variety of reasons. But what we do know are some common concerns listed here on the left. You will be able to see them. Yeah. So some of them are like, will hormones affect my rheumatic disease? Is HRT safe with my existing medications? When do I start and when do I stop? Will HRT make me flare? And a lot of people do express their fears around breast cancer because of earlier research or earlier perspectives that people had. And I would like to take a moment to just quickly touch on the question of when to stop HRT. This is really important, and this has also been raised in a lot of other research, like Hickey and colleagues' work in the Lancet Rheumatology, where they discuss that bone protective properties of HRT are not everlasting. And it is also not recommended for you to take HRT for the rest of your life. So balancing this becomes a very important question. And all of this will be very important to discuss individually with your care teams. I'm going to do a very quick shameless plug to share my colleague Arjun's work, which is currently in press. It has statistics on patients' self-reported triggers and flares of using HRT. or going through the menopausal transition, and also this gigantic list of other triggers and flares. So do stay in touch, or let me or anyone from CAPA members know if you'd like an update. I'm happy to share when it's out. Next, let's just focus in on those patients who did use HRT. If you remember from the last graph, there wasn't a lot of them. The question is, how did it affect them? And the results that I'm going to show you are not medical advice again. You must discuss this personally with your own clinicians, but this data is still promising and very interesting from a research perspective. So I'll show you some stats. It's not been officially published yet, but this is just a big picture. Okay, I appreciate there's a lot on this slide, but I'll break it down for you. You will see that there are 3 graphs. There are lots of different disease groups for you to just look and compare, and RA and IA are circled in red. So as you can see, mostly HRT has improved people's menopause symptoms. But when it comes to effects on their underlying disease, it looks like HRT had no real effect. So like for the majority of patients, it wasn't making it better or worse. And also for a majority of patients, they did say that HRT did improve their quality of life. Of course, this is patients' own self-report. We understand that it can be confusing for some people to delineate exactly what is coming out of their rheumatic condition and what is coming out of menopause. But for some patients, it's very clear, like hot flashes are definitely menopause, and that was kept at bay due to HRT. These results are very interesting, and they form the basis of much more in-depth work that's on our radar now. And of course, as I said, there are some caveats. Our work is retrospective, and a lot of people who did answer a survey were white in ethnicity and very educated. Our survey was also online, so we do know that we might have left out a lot of people who were affected by a digital divide. But we are persistently attempting to overcome these limitations in our future studies. And one of them is planned to be a specific RA-IA focus study, very exciting. If anyone has any methodological or logistic questions about this research, please do get in touch with me later. I'm happy to nerd out and discuss it with you. Now, finally, I have compiled some advice from patients and clinicians for you to consider. You can see if this fits with what you want. But first of all, menopause care is not a one-time event. You have to treat it as a journey with your clinicians that requires check-ins and reviews of how you're doing and what your medications are and your treatments and the dosage for even your HRT, for example. The second is that if you think you need HRT for any reason or you want to try it, do not feel shy to ask your specialists about it. And if HRT or any other treatment for that matter on the table, patients do tell us that they really value clinicians who have an attitude of, I'm not really sure, but I'm not going to keep you hanging. Let's decide together. Let's work together. A more shared decision-making process. And this is very valuable, especially when there are lots of specialties involved, which I find as typical, especially in the UK. And do understand that not every clinician will have an answer to you, because this is genuinely a very under-researched topic with very little data. But that should not stop you from standing up from yourself and seeking care. Third, I want to say that it is not your responsibility to become an expert on musculoskeletal issues and hormones, unless that is actually your job or training. But a little bit of your own research will go a long way. The fact that you are here watching this webinar already means that you're doing a great job at this, and I commend your effort. Self-empowerment can look very different for lots of different people. Some people tell me that they like to keep a note or a log of their symptoms and general health so that they feel more confident when they go to their clinicians. Also, do keep in mind that there can be a lot of stigma about this topic, especially in certain cultures. So for example, I'm South Asian. No one ever talks about this. And there is this whole notion of making women feel embarrassed for having a period, and then making women feel embarrassed for not having a period. And as much as stigma is very pervasive, at the end of the day, this is about your health and well-being. And finding support with associations such as CAPA, which is fantastic in this case, is amazing. And we have to talk more about this topic. We have to normalize these conversations, but also not normalize it to the extent where it becomes an excuse or a reason for dismissal. Like someone saying, oh, your joints hurt a lot? That's normal. Just get on with it, But I'm talking about a balance in conversation surrounding it. And I sincerely hope that through this webinar and by talking to Linda, Dr. Ye, and Dr. Hitchon, you feel less alone in this journey. And also, finally, for any clinicians that might be here in the audience, you have limited time in clinics, and that is completely understandable. And this final piece of advice from clinicians that I've gotten from my interviews will sound really basic, but it is so, so important. You have to ask the patients about menopause and bone health, because at the end of the day, they are dealing with a lot in their lives. And your role in identification and support can really improve their quality of life. And most importantly, do make a point to listen to the patients. And there is a quote here from a GP, which I find very powerful, in which she says that if you don't know the answer, don't be afraid to take some time out to learn more and get back to them. And my hope is that our work supports more of these joined up conversations. I hope that women with arthritis feel less alone in navigating this very obviously convoluted and difficult landscape, and that clinicians feel more confident in understanding and acknowledging the intersection between these two things. And thank you so much for listening to me. If you have any questions, if you want to get in touch, you can contact me here. That's Dr. Mel Sloan, who is my PI/supervisor. And thanks a lot for your time.
Thank you, Kaira. That was very informative. There is a question that came up in the chat, and I'm wondering if we can address it quickly now before we get into the panel discussion. So it's a more specific question about cancer treatment throwing people into menopause overnight. What are some suggestions? I know you're saying to go to the clinician. They're telling us to talk to others and do research. So there's a bit of frustration, as you've highlighted, Kaira, about women having siloed treatment and not really knowing who to go to. Can you
and men as well. There are men in my cancer group that are going into menopause, and they're being picked on by society, like really bullied by society. We don't know what to do. We're tired of being so damn hot all the time. Hot and in pain.
Thank you, Shelley. Thank you, Shelley. So I wonder, Kaira, through your research or your study, did it come up as to which doctors these people are going to, which specialists? Is it endocrinologists? Is it their family doctor? Is it gynecologist? Who are they going to?
This is really hard to answer, especially because it differs from one healthcare system to another. We do have a mini study which focuses exclusively on cyclophosphamide and premature ovarian insufficiency that arises as a result of such a gonadotoxic treatment. And honestly, it's very hard to generalize. So at least in the UK, what I can say is that NICE, which is responsible for writing a lot of medical guidelines, has its own chart and path, especially when it comes to giving people advice on fertility treatments or menopause. So unfortunately, as much as I wish I could tell you exactly where people, especially in Canada, are going to, this is, I think, depending a lot on where you are geographically. And I'm really sorry that I don't have a straightforward answer for you. But I completely understand.
Okay. I just wanted to check in case you did, but it's understandable that people don't.
Yes.
It's a weird thing. But
Yeah.
thank you for answering that. I appreciate it.
Thank you so much. It's definitely like at that point where, as a healthcare system, you really need to pick up the pace, including doctors, clinicians, and the research that we do on the background to help support these decisions. And a really interesting thing also when it comes to this is that, at least in the UK, there has been a lot of push for rheumatologists to discuss menopause and fertility preservation right before they initiate cyclophosphamide. And that's often because cyclophosphamide is a very, as you would know, you'll only do it in severe cases. You have to act fast. There isn't a lot of time to have, take your time and discuss your fertility and menopause. So the guideline here does put the responsibility on the rheumatologist to have these conversations with you. And I'm sure it might be slightly different in Canada, but maybe Dr. Ye and Dr. Hitchon have a much better idea of its application.
Thank you, Kaira. Thank you so much again. This conversation has to happen, and it looks like it is happening through your study. So we hope that will continue.